If everyone can just remember the disclaimer in regards to any of our speakers, they don't necessarily reflect the official guidance of the WHO. Thank you, Sophie. Just a few housekeeping rules. For those of you who would like to ask some questions of Professor Poon or the WHO team, please use the question and answer box that's available for you instead of using the chat box. So that way we can keep everything together. And if you actually see a question that you're interested in and you really want answered, click a like button there, sort of like the thumbs up that you see on Facebook, to actually bring it to the higher end, because we will have the moderated question and answer session after the keynote speaker. All of our webinars are recorded, so you don't need to worry about that, and the flyers for the next webinars will always have the links to the webinar recordings and any other material that is there. And you always will get your next invitation and also the July flyer coming out for you in the next day or two, if not today. So thank you. Next slide, please. So before we actually go into Professor Poon and also this small quick update, I just wanted to quickly introduce our infection prevention and control and clinical management team from Wipro. For example, my name is Peter Ann Zimmerman. I'm an infection prevention and control specialist located in Queensland in Australia at the moment, but part of the team. We have Jocelyn Basile, located in Sydney. We also have Astrid Shotnaki who is living in New Zealand right now. And we also have, of course, the team that is in Manila in the Western Pacific Regional Office. So we have Gary Kunyoshi, and we also have Sharon Salmon and Sophie Dennis, and they're all based in Manila at the moment as part of the Western Pacific Regional Office for WHO. So before we go on to Professor Poon, I'm just going to hand over to Sophie Dennis, who will be talking to you on just some updates around guidance from WHO that's brand new. Thank you. Over to you, Sophie.
Thanks very much, Peter Ann. So just very briefly wanted to give a signposting to the new guidance that was updated and published by headquarters on the 11th of June. And that's on the use of chest imaging in COVID-19. So very relevant, sort of leading into today's talk and discussion. It's a rapid advice guide, and it provides recommendations of when to use chest imaging and which modalities, and discuss the pros and cons of those. It discussed them set within 6 different scenarios. So looking first at those that are asymptomatic contacts of patients with COVID-19, then the different symptomatic patients with suspected COVID or confirmed COVID-19, going from mild, moderate to severe, and finally looking at the use of chest imaging for hospitalized patients to inform decisions regarding discharge. So it's split out into these 6 different criteria and scenarios. The main thing I also wanted to focus on is in the Annex 1. It's an IPC for chest imaging in patients with suspected or confirmed COVID-19. And really pleased to say that Jocelyn Basile, who's one of our team here at the Western Pacific Regional Office, was involved as one of the experts invited to share some expertise and help write this guidance document. So it splits it up into general considerations and then deep dives a little bit more into specific considerations regarding the different modalities. So looking at CT, and then chest radiography and lung ultrasound. So well worth having a look, and that's on the WHO website. Thank you.
Okay, so thank you very much, Sophie, for that update. And so we will provide the link or the document actually in the resources for today as part of the links that you will receive with your flyer for the next session and also for the registration. So without further ado, we will hand over to Professor Poon, who will be speaking to us today about the medical imaging, infection prevention and control considerations that are in the context of COVID-19. 2018. So you would have received her bio, her extensive bio, which is obviously very impressive. And we're very lucky to have Professor Poon here today to speak to us on this subject. So without further ado, I will hand over to Professor Poon. Thank you very much. Over.
Thank you so much. And thanks to the WHO WIPRO team for inviting me to join this webinar. And obviously good day to everybody. And I've been tasked to give a talk on medical imaging infection prevention and control considerations in the context of COVID-19. So in reality, I am an obstetrician and maternal fetal medicine subspecialist based in Hong Kong. So the focus of my talk will be on obstetric ultrasound. Here are my disclosures. Within my talk, I will make a lot of reference to ISWOG, as my society has taken a lot of responsibility in knowledge sharing during the COVID-19 pandemic. So why ultrasound is so important in our field is because it is an integral part of obstetric care. We use it to determine viability, to date the pregnancy, to check if it's a singleton or a multiple pregnancy, to measure fetal nuchal translucency thickness at 11-13 weeks as part of Down syndrome screening. We also do a scan at 18 to 23 weeks to assess morphology of the fetus. We do it for assessment of fetal growth, even for labor management, because we could be checking for fetal head presentation, whether it's head down or head up. And there are obviously other specialist ultrasound services that we provide, such as internal scan to look at the cervical length for prediction of preterm birth risk. And twin pregnancy requires a lot of ultrasound assessment because often these pregnancies are complicated. We also do echo scan of the fetus. We do diagnostic invasive procedures, and we do intrauterine fetal therapy. On the right-hand side, this is basically a dating scan, and this is what we tend to see at 11 to 13 weeks. Why do we raise the concerns regarding the risks of SARS-CoV-2 infection during ultrasound assessment? It is because there are unique attributes that increase the risk of transmission between patients and ultrasound operators and vice versa. And obviously, this is a very, very important list. We keep a very close proximity to the patient because we can't physically scan if the patient is far away from us, or we cannot really keep a safe distance of less than 2 meters. We cannot keep a safe distance of beyond 2 meters or 6 feet. And as you can see in my picture, that was me doing a recent scan, and we are very close to the patient. And ultrasound room is typically very small and closed with very restricted ventilation, and is usually very hot because the machine heats up. The examination time may last for a minimum of 10 minutes to up to 60 or even beyond 60 minutes. And when we do the scan, the woman may be asked to inhale or exhale deeply and hold her breath. And there's a risk of the patient coughing, sneezing, and exhaling heavily. These are all maneuvers that we might ask the woman to do at the time of scan to aid the ease of scan. And in addition to routine ultrasound, we do invasive procedure whereby we could be at a high risk of being exposed to bodily fluids, and we do transvaginal scans and therapeutic and interventional procedures. And then we obviously need to be mindful that we touch the machine very regularly, and such as the screen, the keyboard, the touch screen, the trackball. And so we are obviously concerned that we could be transmitting virus to patients as well. So at ISWOG, we are aware that there are many parts of the world that are still seriously affected by the COVID-19 pandemic. In our opinion, the basic principles in a situation of pandemic are that medical resources should be spared and prioritized. Maximum care should be taken to avoid unnecessary exposure of medical personnel to potentially infected patients and vice versa. And as mentioned, the risk of infection is particularly high during ultrasound investigation due to the impossibility to keep a protective distance between the woman and her caregiver. And the number of visits should be reduced to the essential minimum to avoid virus spread. And in obstetric care, this is a challenge because traditionally a pregnant woman is repeatedly seen during her pregnancy. So how do we actually minimize the number of visits so to protect her and ourselves? So first of all, we thought that it might be useful to provide some guidance on what appointments can be cancelled or rescheduled. And here we can see that existing appointments that have been scheduled before the onset of emergency situation, we're giving some guidance as a society so that our colleagues can feel a bit more comfortable when they are about to cancel a case. So in case of local restrictions and or staff shortage, postponing or cancelling all non-urgent scans for at least 14 days should be considered. The medical team can consider a policy to review the clinical urgency of the existing appointments, depending on the local restrictions, staff availability, gestational age, and indications. If a patient has been exposed to the virus or is known to have been infected, she should be advised not to attend the hospital and to self-isolate for 14 days based on local and national guidelines. But we need to maintain a close communication with the woman because we need to monitor her situation and we might need to bring her in for a scan if she experiences any problems. So we need to, even though if we consider deferring the scan or deferring her antenatal visit, we need to remain close contact with her. So this slide is particularly relevant for areas with widespread community transmission. When scheduling new appointments, we need to consider spacing out the appointments to avoid overcrowding of the waiting room, and patients should be advised to attend with no accompanying person. In my scenario, in my city, we haven't obviously been in a position with widespread community transmission, and therefore within our ultrasound department, we allow one accompanying person. We recommend that a dedicated administrator, assisted by a physician, contacts each patient a day prior to her scan appointment to screen her for symptoms and significant travel, occupation, contact, and cluster, namely TOCC risk factors. In case of symptoms and or positive TOCC, the appointments should be rescheduled according to the prioritization scheme for at least 2 weeks later. And I'll share with you this prioritization scheme in a later slide. And at the first point of contact, we have set up a triage system, as you can see in this video, just outside our ultrasound clinic. We check temperature and take a history of travel, occupation, contact, and cluster. And this video simply shows that this is our setup, and that you can see that both patients and staff are wearing surgical masks. And then the accompanying person is just waiting outside. Here I am sharing with you a template of our checklist for symptoms and TOCC risk factors. We ask about flu-like symptoms to guide us if there is a need for airborne precautions. We ask about history of recent travel, high-risk occupation such as us, history of unprotected contact with a person with confirmed COVID-19, and clustering of flu-like illness or pneumonia. In Hong Kong, we are lucky because actually we are informed of clusters through our Department of Health. So we know about these clusters very easily. And obviously this kind of checklist will not be useful in regions with widespread local transmission, because when you have widespread local transmission, checking whether there are TOCC risk factors is probably not as meaningful as it works in Hong Kong for us. So I mentioned about a prioritization approach for triaging ultrasound services. Our consensus statement provides some guidance as to how you can prioritize the use of ultrasound in obstetric care. And I'm sure this can be easily adopted for other specialties as well. The proposed options for managing appointments and clinical pathways will need to be customized by each individual unit, depending on local protocols and guidelines, staffing and infrastructure. The dilemma for us is to continue using ultrasound diagnostic capabilities where indicated, while reducing the use to the essential minimum and to patients with urgent indications. We have established a 3-tiered recommendation pathway to prioritize scheduling scans based on type and indications according to the following options. Scans that can be cancelled for the duration of the pandemic, the blue tier, as you can see on the left-hand side. scans that can be delayed for a few weeks without affecting clinical care, the green tier, a scan that need to be undertaken without delay, the red tier. A distinction should be made between scans that are part of routine ultrasound practice, so within the blue tier, such as the routine first and second trimester scan for evaluating morphology and risk of Down syndrome, or are needed in view of an increased risk of background problems such as known history of preterm birth, fetal anomalies, placental insufficiency such as preeclampsia, fetal growth restriction, and maternal conditions such as the development of preeclampsia, diabetes, or when there are risk factors emerging in pregnancy. In the red tier, so these are medical indications for the mother when they present with bleeding, abdominal pain, or severe preeclampsia with critical illness, or even for fetal indication, because in obstetrics, the fetus can be in trouble as well, such as in a twin pregnancy, that could be acute twin-to-twin transfusion syndrome, whereby both babies could likely to die as a result of the severe complication, and that we need to do something urgently. And in the case when we need to do urgent intervention, then we need to see the patient with obviously personal protective equipment. And when there could be fetal abnormalities, or when the baby is suffering from severe growth restriction, or that there is an ill patient with COVID-19, that we need to arrange urgent emergency ultrasound for these patients. So this is another slide in relation to how we guide our fellow colleagues in terms of modification of a routine ultrasound scan, as well as for Down syndrome screening. We propose how you can modify the schedule of these services, and that is based on whether the woman is symptomatic for COVID-19 or symptomatic asymptomatic for COVID-19, or symptomatic and or with screen positivity for TOCC. As I mentioned, 11 to 13 weeks as a routine scan for both dating and screening for Down syndrome. And I think I don't need to explain about this process. And what we tend to do is, if a woman is asymptomatic, and that this is, you're not in a widespread transmission region, then we should offer the routine combined test with the fetal nuchal translucency measurement. And then, but if there is concern, you can then also offer a non-invasive approach, which is simply a blood test. And the reason why we think this is an important aspect is because offering non-invasive prenatal testing is a more sensitive screening method in comparison to the routine combined test. So basically, when it's more sensitive, it means that there will be a much lower false positive rate, and therefore the need for invasive procedure. As I mentioned earlier, an invasive procedure is obviously at a high risk ultrasound scan, because the practitioner is likely to be exposed to bodily fluid. So basically, whatever we do, we are trying to minimize the number of women needing invasive procedure, and therefore protecting both the clinician as well as the patient from being exposed to bodily fluid. And if a woman is asymptomatic, we'll just offer a routine anatomical scan, but normally we do it between 20 to 22 weeks. So during the pandemic, we have advised to widen the gestational age window to account for cancellation. And just for those of you who are not familiar with obstetric care, and normally there is a cutoff in terms of when you can consider for termination of pregnancy. In some regions, obviously termination of pregnancy is not allowed. In some regions, that can only be done before 20 weeks. In some regions, that can be done before 24 weeks. So in our line of work, we are always kind of racing against time, because we need to continue with providing almost the same standard of care, making sure that we detect all these anomalies in good time, so to allow for reproductive choices in a timely manner. So this is why our job can be quite challenging. Maybe not so much for asymptomatic patient, but for symptomatic patient, we also have a guidance. So if a patient has symptoms and or she is screened positive for TOCC, then we need to reschedule the combined test in 2 weeks, if still within the gestational age window, because that age window is only between 11 to 13 plus 6 weeks of gestation. If that cannot happen, then we offer NIPT. And as I mentioned, NIPT is a more sensitive test than the routine combined test, but obviously, well, for me it's obvious, so not for all of you. It is actually more expensive, so it might not be available to other people. Then we will also have a third option. And following screening and following the quarantine, a period of quarantine, we expect that the patient might have already missed the routine 11 to 13 week scans, and therefore we suggest that the woman should still be offered a scan in 2 to 3 weeks time after quarantine. Why is that? Because you know, the second slide of my talk, I listed out all the things that we do, and if a woman has missed her first scan, we have no idea. Is it a twin pregnancy? Is it a singleton pregnancy? We don't know the gestation. So actually the first scan is critically important for every pregnant woman, and that we need to try our best to maintain this first scan. If it's beyond 11 to 13 weeks of gestation, we need to try to do it at the earliest opportunity, provided that it is safe for the patient and the healthcare professionals. And then for the routine morphology scan at 18 to 23 weeks, and our advice is that the woman should be given another appointment in 2 to 3 weeks time after quarantine. And some disclaimers in the bottom, as I have already alluded to the fact that we are always working against a timeline, so that we need to try and maintain service and maintain the same standard of care, but without compromising the patient and without compromising our fellow colleagues. So how about for women with suspected, probable, or confirmed COVID-19? So obviously some patients are managed as outpatient. Then the management for these routine standard scan would be similar to what I showed you before. We need to reschedule in 2 weeks if it's still within the gestational age window. And if that cannot be done, we need to offer other type of screening for Down syndrome. And as for the morphology scan, we need to reschedule in 3 to 4 weeks following recovery. And in hospitalized patient, and they probably get a better deal in the sense that we will obviously plan to see the patient in hospital. The dating scan, as I mentioned, is a critically important scan for all pregnant women. Then we need to perform that at bedside, and I'll cover the issue of this later on as well. And if possible, we will offer both either NIPT or serum screening, the second tier screening. And then for the 18 to 23 weeks, it's important to carry out the scan, not just for the morphological assessment. We also need to check where the placenta is, because when we don't know where the placenta is, then there's a risk for the mother, because if the placenta is what we call low lying, which means it's blocking the birth canal, then if a woman goes into labor and we don't know where the placenta is, then this woman could be at risk of excessive bleeding. So again, for hospitalized cases with COVID-19, we recommend performing this bedside scan for assessment of morphology, but we also recognize that maybe we can only do a targeted scan because the patient is critically ill. So within our consensus, we try to share with our members and fellow colleagues our thinking, some guidance to ease their workload in some way, and to help them and give them some consensus, so to make it a bit easier for our fellow colleagues. So I want to also briefly mention about diagnostic invasive procedures. It is part of our job, and you can see on the right hand side of videos, the top one is a procedure that is ultrasound guided that we call an amniocentesis. We introduce the needle under ultrasound scan guidance to collect the amniotic fluid around the fetus. This is something that is important if a woman is at risk of having a fetus with Down syndrome, and because we, as I mentioned, we try to maintain the same standard of care. And if a fetus is affected by Down syndrome, then we can offer either termination of pregnancy or expectant management, and there is a timeline for that. And the bottom video is basically a competing procedure is done at 11-13 weeks. It's what we call chorionic villus sampling. And then basically we are taking a biopsy from the placenta. Why is it a challenge, and why do I bring this up? Because till now, no data, well, limited data are available on fetal and perinatal complications when infection is contracted in the first and early second trimesters, a time when these invasive procedures may be performed. So we actually do not have any idea whether doing these procedures increase the risk of viral shedding. And that might be even more specific for chorionic villus sampling, because we are actually puncturing the placenta, which is a vascular organ. And right now, our recommendation is that given that if a patient is potentially exposed, or that a patient is confirmed to have COVID-19, then we are suggesting a delay in seeing these patients by 14 days. So it seems that it is more reasonable to perform an amniocentesis, because that procedure is usually done after 16 weeks of gestation, and for CVS that is before that is between 11 to 13 weeks of gestation. Sorry. So I'm showing you an example of an algorithm for management of pregnant women in need of ultrasound assessment during the pandemic. Women presenting with vaginal bleeding and or abdominal pain during the first trimester of pregnancy. We're worried about ectopic. Ectopic pregnancy is basically pregnancy that is outside of the uterus, is typically present in the fallopian tube, and that could be a life-threatening condition. And then these patients will need to be scanned promptly and followed up as indicated to ascertain viability and to rule out ectopic pregnancy. Sorry. And then if the woman doesn't have vaginal bleeding or abdominal pain, and without risk factors for ectopic pregnancy, such as previous history of ectopic, then they should undergo routine first and second trimester scans, as I already covered that in my previous slides, to screen for fetal Down syndrome screening, fetal Down syndrome, and structural anomalies. And when fetal abnormalities are noted, then, or that there are other maternal and fetal indications, then we need to arrange follow-up scans as suggested. In case of twin pregnancy, fetal growth restriction, fetal anomaly, or amniotic fluid abnormality, too much or too little, then follow-up scans are necessary, and frequency of such scans will depend on the indications and gestational age, and we consider utilization of fetal Dopplers that should be individualized. Earlier, I have already touched on our proposed modification of routine ultrasound examinations in women with suspected, probable, or confirmed COVID-19. So in the event when a pregnant patient has suspected, probable, or confirmed SARS-CoV infection that requires an ultrasound scan, here are recommendations. All attending medical staff should don appropriate personal protective equipment prior to entering the examination room. We suggest that a bedside scan with the patient in situ should be done, rather than having the patient transferred to a dedicated ultrasound department. If feasible, it is recommended to have one or more dedicated ultrasound machine for patients with suspected, probable, or confirmed SARS-CoV infection. If the patient must be scanned in the clinic, this should be done at the end of the clinic list, as the room and equipment will subsequently require a deep clean. It is obviously imperative to perform hand hygiene once the gloves have been removed. And here, we actually even have a recommendation regarding PPE during ultrasound, and we have provided our suggestions of the use of PPE according to 3 groups of patients: asymptomatic and TOCC negative in a region in which there is no widespread community transmission, so the extremely low risk patients. And we have also divided the recommendation according to asymptomatic and TOCC positive patients, and those with suspected, probable, confirmed COVID-19, or where there is widespread community transmission. So for the first column, in our setting, we all change into our dedicated work clothes on arrival. And at the end of the day, we discard our dedicated work clothes in a dedicated collection point. We observe hand hygiene, of course. We wear surgical face mask. There's no need for respirator. There's no need for isolation gown. But actually, some of us wear disposable gloves, but there's no need for eye protection or hair cover for the first column. And our recommendation for the second and third columns are actually identical. Of course, we should wear dedicated work clothes. We should observe hand hygiene. There's a need of fit tested respirators, and all of us are fit tested when we first joined our department. And we need to wear disposable, fluid resistant and impermeable protection gown. We double gloves, and we wear goggles or face shield, and we wear hair cover for the second and third column patients. We have special attention, special consideration for transvaginal scan or invasive procedures, as I mentioned, because of the increased risk of being exposed to bodily fluid. And transvaginal scan is also is an endolumen scan, and therefore there is an additional risk in comparison to a routine transabdominal scan, unless the abdomen has an exposed wound. For asymptomatic and TOCC negative patients, we advise on standard condom or commercial transducer cover. And for the second and third columns, we recommend standard condom or commercial transducer cover. And also we would recommend covering the cable if there is a cable cover. And in terms of staffing, as I have already mentioned, that ideally the scan should be done at bedside rather than in a clinic. We need to minimize the number of staff in the room and ensure that the most appropriate person is undertaking the scan. Rather than sending a junior doctor, we should really consider the most appropriate person in undertaking the scan, because we want to do it all in one go without having to ask for a second or third opinion following the first scan. Another aspect of ultrasound scan is the preparation and cleaning of equipment. As we have learned that SARS-CoV-2 or other SARS-related associated viruses have been found in a laboratory environment to be viable on plastic and stainless steel surfaces for up to 72 hours. And whereas on copper and cardboard is viable for up to 24 hours. And this is particularly relevant for ultrasound systems because the machines are all plastic. And so we need to make sure that we do not have the ultrasound machine as a medium for transmitting the infection. The ultrasound room should be cleaned thoroughly each morning, and all contents should be wiped with a compatible low-level disinfection. And these contents include the ultrasound monitor, the computer keyboard and mouse, a transducer holder, gel container, door handles, cabinet knobs, and so forth. The number of transducers connected to the ultrasound machine should be reduced to a minimum, as you can see in this picture on the right. Usually we recommend one transabdominal and one transvaginal probe, and all other transducers should be stored safely in a clean, closed cabinet and brought up as needed. Ultrasound transducers and cables should be cleaned every morning, and this should be also performed after each scan. And SARS coronavirus, MERS, and endemic human coronaviruses, and obviously this is the work with Jocelyn, and we have learned that these viruses can be efficiently inactivated by surface disinfectant procedures with 62 to 71% ethanol, 0.5% hydrogen peroxide, or 0.1% sodium hypochlorite within 1 minute. And we also recommend other biocidal agents. And then it is also important to check the required contact time for each of these cleaning products. And when it comes to cleaning, when it comes to preparing ultrasound transducers, there are essentially two steps. The first step is cleaning, and the second step is disinfection. Any products used for cleaning or disinfection must be compatible with the ultrasound equipment as determined by the ultrasound equipment manufacturer. Certain products may damage the ultrasound equipment or transducers and invalidate the warranties. So it's obviously, if in doubt, you should check with your local distributors or your companies. And cleaning is an important aspect, a very, very important first step, since any remaining gel can act as a barrier to the disinfectant, thus diminishing its efficacy. And the USA CDC defines cleaning as the removal of foreign material from objects and is normally accomplished using water with detergents or enzymatic products. Ineffective cleaning prior to disinfection can limit the effectiveness of chemical disinfection. Current guidelines for cleaning transvaginal transducers recommend using running water to remove any residual gel or debris from the probe before cleansing thoroughly the transducer using a damp gauze pad or other soft cloth and a small amount of mild non-abrasive liquid soap. The use of a small brush, especially for the areas of angulation, should be considered. Depending on the design of the particular transducer, the transducer should then be rinsed thoroughly with running water and dried with a soft cloth or paper towel. Regarding disinfection, always refer to your facility's infection control policies and protocols, as well as the transducer manufacturer's instructions for use and labels for use. Disinfection practices are evolving constantly, and what I provide here is the most current to date. And high-level disinfection is recommended for transvaginal but not transabdominal transducers, and specific product instructions should be consulted. There are two available disinfection methods. The first is chemical disinfection. Here we provide some suggestions, and here on the right, it was me using Tristel in cleaning our transvaginal transducer. And the next option is automated high-level disinfection. And then again, we provide some suggestions here. And then in my unit, we have access to Trophon, which is a device with sonicated hydrogen peroxide mist. And then this is a demonstration of how we use Trophon in our clinic. So there's quite a lot to consider when we're providing ultrasound services for our obstetric patients. And I hope you have found this talk useful and potentially applicable in your setting, even though you don't provide obstetric care. And please stay safe and healthy, and happy to take any questions. Thanks a lot.
Thank you so much, Professor Poon. That was fascinating, I have to say. You know, I think one of the things that you particularly highlighted was the use of environmental and administrative controls, which really has an impact on how you manage your patients, and also how you manage the practice and putting in those control measures for COVID-19 specifically. So I think that really highlights for the participants how important those environmental and administrative controls are. So, for example, I did have a question actually in relation to, for example, administrative controls. So so one of the questions is to minimize contact time with patients with suspected or confirmed COVID-19. Can the ultrasound scans be modified to only review critical morphologies or abnormalities?
But the trouble is you need to have your first screening scan, because we wouldn't know. We wouldn't know whether there are structural anomalies until you do your first scan, and therefore it's highlighted in my talk that essentially we can not really remove all scan components of obstetric care. I suppose the minimum that we need to offer is the 18 to 23 weeks morphological scan, because at the same time we could also screen for some features of Down syndrome. And in some parts of the world, they might have already skipped the 11 to 13 week scan for Down syndrome screening and dating, and they might have already offered NIPT. But as I mentioned, is a more expensive test, and therefore it might not be available to everybody. And so some, let's say the United States, I'm sure some hospitals or obstetric units have already, scrapped the 11, 13-week scan, offer an IPC, and then offer an 18 to 23 weeks morphological scan, because in order to detect if there is a morphological abnormality, we need to do that initial scan. And from my point of view, because I'm a maternal fetal medicine specialist, I deal with abnormal cases. So then they need to come to us. And by then I cannot say I would need to basically see these patients with full PPE, because it's really going to be down to me to finalize the diagnosis and then to offer reproductive choices to the pregnant women in a timely manner. That has to be done at least in Hong Kong before 24 weeks, because imagine if we don't offer the timely assessment, and the patient misses the opportunity to be given the choice, to be given the reproductive choice of continuing or stopping the pregnancy. That would have lifelong implications for the family and the child.
Excellent, thank you so much. So I have got a couple of questions regarding personal protective equipment that you recommended for various aspects. So one of the questions in the Q&A box is actually, why do you recommend the use of double gloves for scanning?
So basically, first of all, when we scan, we are very close to the patient, and basically we are well, the gel itself, and also in particular the transvaginal scan, that would be exposing us to bodily fluid. So and you might argue that you don't need to double glove, but then in our experience we scan for a very long time, and actually one glove is actually not enough. Often I'm covered in gel at the end of the scan. I think it's more of a practical issue here, that when I'm doing a scan and if I think I'm going to be at risk for exposure to bodily fluids of the patient, then one glove is certainly not enough, and is almost the same for us as we do for an operation, because I'm always covered in gel even with one glove. This is more, I suppose, speaking from personal experience. Yes.
Understood. Thank you for that. And so another question regarding PPE, with regards to the rationale behind using the N95 masks for delivery and transvaginal ultrasound for suspected and confirmed COVID-19.
So basically for confirmed, suspected, because that could be later confirmed. So basically suspected COVID-19 or confirmed COVID-19 patients, our approach will be the same in terms of PPE. And as I already alluded to the fact that during the scan, although it seems to be quite safe, but I will be forgetful, and I will ask the patient to exhale, inhale, and so basically there would certainly be a need for the use of a respirator for such scan. I mean, okay, it's not at the same level as intubation, but certainly, actually, I came across in India, they've actually developed a screen to basically completely divided the pregnant woman from the ultrasound operator to minimize the spread as well. So I think, and in Hong Kong, our best practice is that basically in any encounter with a patient with suspected or confirmed COVID-19, we will wear a respirator. So be it ultrasound scan, be it for intubation.
Thank you very much for that. And I think, you know, when you spoke about what they're doing in India, I think there is a question as to how will COVID-19 affect ongoing care. So we hear about the new normal. So do you think, from what we've been doing in regards to COVID-19, do you think that this is going to have an on-flow effect as to how we manage patients into the future?
Very good question. I think it would change our mindset going forward. And because in many parts of the world, such as India, telemedicine has really played a very important role in ensuring adequate care and safety for the pregnant women. And but of course, telemedicine, a phone call, a video call cannot really replace the personal touch. It cannot really replace the need of face-to-face assessment. There will still be times when we must see the patient in person. But then I suppose I can only predict that with such a pandemic, people have become creative, people have become more innovative, and going forward, I think we will certainly be utilizing more of telemedicine or other means of getting through to our patients. But then I suppose we need to really find a balance between telemedicine and face-to-face care. And in our line of work, it's actually quite difficult. I mean, I cannot remotely assess the fetal size, for sure not. I can only remotely assess if the patient is clinically well, any symptoms, how are the fetal movements, but we cannot replace our ultrasound scan, which obviously can only be done face to face, and the patient cannot do it herself. So, but then I think there will be aspects of prenatal care, obstetric care, or even for other specialties going forward that we should look into integrating both telemedicine and in-person management.
Excellent, thank you. So we've got some questions in the Q&A box, and just a reminder, if you do have any questions, if you could type them into the Q&A box, not into the chat box, that would be great. So in regards to, there was a question in regards to enhanced cleaning in the environment. So the question is, did you do enhanced cleaning of the environment generally during the period, like during this period that we're experiencing now?
Please explain to me what enhanced cleaning means. I think
Okay.
I think it's I think it's an infection. But anyway, of course, we have dedicated staff for cleaning all services on a regular basis, if that is what you mean.
Yeah, so I guess the enhanced cleaning has there been more focus in your clinical areas around, more frequent cleaning of frequently touched surfaces, for example?
Absolutely. Even in our offices, before COVID-19, I mean, we did not have a dedicated person to clean everything. I mean, every morning we have a member of staff cleaning all highly touched surfaces in our offices as well as the clinic. So that is done very regularly, we've been exceptionally mindful, because I suppose everybody, not everybody, at least the city of Hong Kong has been scarred from the first SARS-CoV epidemic. So we are a bit over the top, but it's for the better.
Thank you. So yeah, as we discussed previously, a number of our members from the network are working in lower income settings, for example, or lower resource settings. So one of the questions that we have here is, in regards to disinfectant, is there any type of homemade disinfectant that you can recommend, since not all institutions can, meet for example, the level of disinfection that you are able to achieve, for example, in Hong Kong? Any alternatives? So, for example, you did suggest, for example, the 0.1% bleach or sodium hypochlorite, which is generally available. But I'm not sure with this question if it's relating to the disinfectant of the transvaginal probe, for example. So, can you give any advice around that?
That would be a difficult one. I think for transvaginal probe, we do really see it as a high risk procedure, and therefore I at the moment I don't think I can recommend any homemade disinfectant specifically for the transvaginal probe cleaning, unless the rest of the panel has other suggestions.
No, I appreciate that. And yeah, as you identified, there are a number of different wet chemical disinfectants you identified for transvaginal probes, and that can be including, the old-fashioned glutaraldehyde, but we do have more safer options, which you actually listed as well. So perhaps maybe for those who are wondering about that, maybe have a look at the recording just to refresh your memory about the suggested disinfectants. But for environmental cleaning and disinfection, you were even suggesting the normal household bleach, for example, that could be used, correct?
Yeah, yes.
Beautiful. Thank you. So just another question in regarding PPE. PPE is usually a hot topic, Professor Poon. So do you change the personal protective equipment if you're performing invasive ultrasound procedures, even in an asymptomatic patient who may not have been tested?
That depends on where you are. So I suppose in Hong Kong, we don't have widespread local transmission, and so the answer is no. Basically, the minimum that we do is, I don't know, it's okay to go back to my slide, we wear our dedicated work clothes, hand hygiene, surgical face mask, and disposable gloves. But in that context, I will also wear a pair of goggles, but not full PPE. But if you are in a region with widespread local transmission, and you can't really differentiate who has the infection or not, and given that we have learned from New York data that in a highly endemic area, the rate of SARS-CoV-2 positivity in asymptomatic pregnant women is around 13%. So on that basis, you might have no choice but to consider wearing PPE for doing the invasive procedure in a highly endemic area. But so because you cannot differentiate who could be a silent carrier.
Thank you so much. I'll just ask just one final question. I'll probably try and put these two together that are in the Q&A box. So there is a question in regards to the cleaning and disinfection of equipment. Is that done between every patient use? So for example, even if you like talking about the bed sheets, the treatment table, and also who's responsible for cleaning the equipment after use?
I think it's a joint effort, and we are lucky where I am is that I always have an assistant, and the assistant is fully trained to clean the transducers, the equipment, and the couch and things like that. But I think it's also my responsibility to be aware of how this should be done as well. Because often what happens is that you see a patient and afterwards you start typing your notes, and then the assistant will start cleaning. So to save time, otherwise you might need to add additional 10 minutes to it, because someone asked me about this. How much time do you need to add on to your clinic to ensure appropriate cleaning has been performed for the equipment? So I suppose it's teamwork, and often my assistant is ahead of me, and then he or she would go ahead and clean the procedures, the equipment, and then all of them would be trained, and I'm trained as well.
Thank you. All right, so I'm just going to, personally, thank you very much, Professor Poon, but I'm just going to hand over to Joss to wrap up the session for today. Thank you.
Thank you, Peter-Ann. Thank you so much, Professor Poon, for your time and your valuable experience dealing with COVID-19 and obstetric care. We're really excited to hear your presentation, because you've managed to combine clinical management and IPC into your presentation, which is what our team represents at WIPRO. And on behalf of everyone on the team and all our listeners, thank you again for just being here, and for everything that you've shared with us. So on that note, if anyone at the Manila office has nothing to share, thank you everyone. Peter-Ann has put up a slide here for next week's webinar on community hand hygiene, Papua New Guinea experience. So for all the delegates listening, please do register online. Thank you again, Professor Poon, and I'll pass on to Peter-Ann to close. Thanks, Peter-Ann.
Thank you, Jocelyn. And thank you again, Professor Poon. So just a reminder that the July focus is actually on community engagement. So we're having a wide variety of speakers for this month's focus. I hope everyone can join in. Please share the flyers that we'll be sending out in the next day or so. Share it widely throughout your networks. And I think this is an opportunity to truly understand what the role of infection prevention and control is in the community, and it's not limited to our acute care facilities. So again, thank you very much. Wishing everybody a very safe and happy week, and we will see you next week. Over.